Okay, so we are going to discuss the hyperthyroidism thyroid storm critical care station. Patients going for laparoscopic cholecystectomy recently complained about palpitation, weight loss, and diarrhea. ECG was done, which will be shown to you. Lab results are high T3, T4, and low TSH. So, what is your diagnosis considering the lab results? So, this is primary hyperthyroidism because your T3 is high, T4 is high, and TSH is low. So, this is typical hyperthyroidism. And what are the causes of hyperthyroidism? So, thyroid overactivity, grave disease, okay, salutary toxic adenoma, and toxic multinodular goiter. Early stages of Hashimoto thyroiditis, but later Hashimoto goes to hypothyroidism, and TSH secreting pituitary tumor and mutation causing constitutive activation of TSH receptors. So, extrathyroidal administration of T3, T4, and ectopic thyroid tissue. So, these can cause hyperthyroidism. Okay, so what are the stages of thyroid hormone synthesis? So, we will go for it from here. So here we have the different steps for the thyroid hormone synthesis. We will also go through this station as well, but here, so can you describe the synthesis of the thyroid hormone? Yes. So iodide ions enter the thyroid follicle. So let's suppose these are the thyroid follicles, and we have the thyroid follicle. So iodide is thyroid follicle cell by active pumping. So here is the pump. So this iodide will go inside the cell. Okay, iodide is converted into iodine by the tissue peroxidase, thyroid peroxidase. So thyroid peroxidase converts the iodide into iodine. Remove this negative charge. So remove this negative charge, this will be your iodine. Iodine usually remains in I2 state, but iodine combines with tyrosine forming monoiodide. So here we have uh, tyrosine in the thyroid cells or thyroid follicles. So what they do actually. So basically, the thyroid gland is in the form of follicles like this. So here they are. These are the different cells, and they have formed a thyroid follicle. So in the center they have a colloid. So they have tyrosine. Tyrosine combines with iodine to forms monoiodotyrosine and diiodotyrosine moieties. Okay. So MIT and DIT, monoiodo, diiodo, they form the triiodotyrosine and diiodo compound to form the tetraiodotyrosine. But the active is your body active is triiodotyrosine or triiodothyronine. So T3 is the most functional, but very less in the body, and T4 is a non-active or like not the active hormone, but large in number. So what happens that in the body, in the periphery, the T4 is also converted into T3 whenever required. So beta blockers activate this mechanism that they prevents the conversion of T4 into T3. So these are the steps. So what are the function of T4? What are the function of T4? So hot chronotropic and inotropic effect. So chronotropic, it increases the heart rate, and inotropic, it increases the heart contractility. Increase the number of beta receptors on the heart, enhance response to circulating catecholamines, increase proportion of alpha myosin heavy chains, higher ATPase activity. So they increase alpha myosin heavy chains in the heart. heavy chains, alpha myosin heavy chains in the heart. Adipose tissues catabolic, so they stimulate lipolysis, they increase protein breakdown, bone, they do promote normal growth and skeletal development, and nervous tissue development, promote normal brain development, gut metabolic, increase the rate of carbohydrate absorption, and lipoprotein metabolic, formation of LDL receptors, low density lipoproteins, others. So calorigenic because it increases basal metabolic rate, stimulated oxygen consumption by metabolically active tissues, exception testes, uterus, lymph nodes, spleen, anterior pituitary, increase in metabolic rate. So they increase basal metabolic rate. So considering the lab results, will you do his surgery? No, because he is in hyperthyroid state. Why? What are the possible complications if a patient went to surgery without correction? So there can be thyroid storm, thyrotoxic crisis, and high risk of MI because the heart will beat more. So whenever there is tachycardia, like very high rate, so it can lead to uh, MI. So how is thyroid hormone metabolized? So T4 and T3 are deiodinated in the liver, the kidneys, and many other tissues. These deiodination reactions serve to catabolize the hormone and provide a local supply of T3, which is the primary mediator of the physiological effects of the thyroid uh, secretion. So yes, if T4 is catabolized to T3, so it is active and help in functions of the body. So what are the clinical features of hyperthyroidism? So exophthalmos, sweating, headache, goiter, weight loss, nervousness, emotional instability, oligomenorrhea in women, and arrhythmia and tachycardia, nausea and diarrhea, and tremors and muscle weakness, proximal myopathy. So these are the features of hyperthyroidism. How will you prepare the patient for operation? So traditional preparation aims to make the patient biochemically euthyroid at operation. So you have to make the patient euthyroid. So carbimazole 30 to 40 milligram per day is the drug of choice for preparation. When euthyroid after 8 to 12 weeks, the dose may be reduced to 5 milligram 8 hourly. For example, uh, 5 milligram 8 hourly, so 5 milligram TDS in 24 hours. So carbimazole 30 to 40 milligram per day is the drug of choice for preparation, and when it's euthyroid after 10 to 12 weeks, the dose may be reduced to 5 milligram to 8. An alternative method of preparation is to abolish the clinical manifestation of toxic state using beta adrenergic blocking drugs. So you can use the beta blockers. These act on the target organs and not on the glands itself. Propranolol also inhibits peripheral conversion of T4 to T3. So you can give the beta blockers, so they will act on the target organs where the functions of the uh, thyroid hormones are executed. So and also they will convert the T4, block the conversion of the T4 into T3. So ECG was that interpret this. So here we have the absent P waves. There is no P waves here specifically. Here no P waves. And irregular rhythm, because you can check here that ECG interpretation is also a part of it, so you must practice it, denoting atrial. So this is the picture of atrial fibrillation. So you can see that we have here 1 2 3, almost 3 boxes, and here 1 2, only 2 boxes, and so on. Here is only 1 box, here 2.5 or 2, and here 2 complete, and here 2 full. So here 2.5. So you can presume that this is not a regular rhythm, and when the rhythm is not regular, so how to calculate the heart rate? So we calculate the heart rate by we take 30 hour waves. For example, this is 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17 18 19 20 21 and so on. You took 30 RR and then calculate the number of large squares and multiply it by 10 when the rhythm is not regular. So this will gives you the heart rate. And when the rhythm is regular, so you took the number of odd waves, the number of large squares between two odd waves, and divide 300 by the number of large squares between two odd waves. So this will gives you the heart rate. So this is how we read or calculate the ECG. So here this is the picture of atrial fibrillation. So what are the clinical pictures of thyroid storm? So this is an acute exacerbation of hyperthyroidism occurs if a thyrotoxic patient has been inadequately prepared for thyroidectomy. So clinical features will be dehydration, hyperpyrexia, restlessness, irritability, delirium, convulsion, tremor, atrial fibrillation, and GI symptom, nausea, vomiting, and diarrhea. So these are the how will you manage? So this is a critical care station condition. So you will manage according to CRISPR protocol ABC manner. So give first oxygen, high flow oxygen, IV fluids for dehydration, cooling the patient ice pack because there is hypothermia, and diuretic for cardiac failure, digoxin for uncontrolled atrial fibrillation, sedation, and IV hydrocortisone. And specific treatment is carbimazole 10 to 20 milligram 6 hourly. 10 to 20 milligram 6 hourly. Logol's iodine 10 drops. Logol's iodine is given 10 drops 8 hourly by mouth or sodium iodide 1 gram IV. So you go for sodium iodide or Logol's iodine. Logol's iodine 8 to 10 drops 8 hourly or sodium iodide 1 gram IV. Propranolol intravenously 1 to 2 milligram or orally 4 to 40 milligram 6 hourly will block the beta-adrenergic effects. Glucocorticoid to reduce peripheral conversion of T3, T4 to T3 and control the shock. Hydrocortisone 5 milligram per kg 6 hourly or dexamethasone 0.2 milligram per kg per day are used. Bile acid suppressants to prevent reabsorption. So we give bile acid suppressants to prevent reabsorption of thyroid hormones from the gut. Cholestyramine 4 gram 6 hourly is given. And digoxin cardiac monitoring is crucial. What is Local's iodine? So also known as aqueous iodine and strong iodine solution is a solution of potassium iodide with iodine in water used to decrease the effects of TSH, thyroid stimulating hormone and the gland, and inhibit iodine binding and decrease the vascularity of the gland. The effect is temporary, can be used in the pre-operation as well for the control of severe thyrotoxicosis, but not so for long-term control. Where to manage patient in the intensive therapy unit because this is a critical care condition. So yes,